So we're thrilled today to be welcoming Dr. Satyan, who agreed to join us today to talk about pulmonary hypertension and also about leadership and the role of women in leadership in neonatology. Dr. Satyan completed his fellowship at the University of Buffalo and then working on a J-1 visa, had to work as a pediatrician for a few years and then went back to the University of Buffalo where he rose in the ranks and performed incredible studies looking into the comprehensive mechanisms around pulmonary hypertension and the treatment and clinical treatment for pulmonary hypertension. And he then moved to California, where he is currently professor and chair of the Department of Pediatrics at the University of California, Davis. And he is an esteemed speaker on pulmonary hypertension, an illustrator, mentor, and a leader in our field who really has his finger on the pulse of so many important issues in our field today, including workforce, staffing, gender equity, and of course, the most important clinical care of our sickest babies who have pulmonary hypertension and congenital diaphragmatic hernia. So we're just so thrilled that he agreed to join us today and look forward to this talk.
Thank you, Dr. O'Reilly. Thank you for the kind introduction and for inviting me here. Let me share my screen. A question a couple of you asked me when you saw my tweet was as to what's the relationship between these two topics. There is no relationship at all. I'm sorry to disappoint you. These are two of my favorite topics, and hence I put them together. Thanks to Dr. O'Reilly for permitting me to do this. So I'll start off with a talk on PPHN. This will probably take around 35 minutes, and then we will move on to the talk on leadership, which is probably the one that most of you want to hear anyhow. Can you all see my screen? Great, okay. So let's start with PPHN. This is, as all of you know, it's persistent pulmonary hypertension of the newborn. I will limit this talk to term babies, and the subtitle for this talk is as to what the fetus can teach us. If you think of pulmonary hypertension on the whole spectrum in the NICU, you have a fairly wide range. For example, we think of babies with black lung PPHN. Here is a baby with an X-ray on ECMO. We also think of acute PPHN in infants, typically term and late preterm or post-term infants with meconium aspiration syndrome that classically present with fluffy lung fields and hypoxic ischemic encephalopathy. Some of them might have hypoxic ischemic encephalopathy and go on for therapeutic cooling. We also deal with congenital diaphragmatic hernia, which is a common condition which is associated with both acute and chronic pulmonary hypertension. We often deal with acute early pulmonary hypertension in extremely preterm infants. I will not be talking about this particular entity today. And of course, the last entity, but not the least, is chronic and late pulmonary hypertension with BPD in babies with older preterm infants with bronchopulmonary dysplasia. As you can see with all the scarring and fibrosis on these X-rays and the CT scan. Some of these babies might also have pulmonic vein stenosis contributing to pulmonary venous hypertension. So this is how we as clinicians think of the different presentations of pulmonary hypertension in the NICU. But I would recommend that you use a more physiologic approach when you think of pulmonary hypertension. Whenever you see a patient, think of the formula for pulmonary arterial pressure. For example, mean pulmonary arterial pressure is equal to pulmonary vascular resistance times right ventricular output or pulmonary blood flow or cardiac output plus pulmonary capillary wedge pressure. So if you think of these three entities that contribute to increased pulmonary arterial pressure, each of these entities can result in pulmonary hypertension, and they all can present in a very similar fashion in the newborn period. If you assume this illustration to be that of a normal heart with right-sided structures over here with blue blood and left-sided structures with red blood over here, a baby with pulmonary hypertension secondary to increased pulmonary vascular resistance or a resistance-driven pulmonary hypertension typically presents with hypoxemia, increased right ventricular pressure, the interventricular septum bulging towards the left, compromising the LV preload, and typically a right to left shunt across the PFO and a right to left shunt across the PDA. This is classic of babies with increased PVR causing pulmonary hypertension. Similarly, some of us who are senior enough, or some of those of you who have been lucky enough to see patients with a flow-induced pulmonary hypertension, for example, if you have a baby with a vein of Galen malformation, initially it's not easy to figure out if this baby has pulmonary hypertension or something else. And until somebody listens to the scalp, finds signs of failure, and then does an echo and a head ultrasound to figure this out, some of these babies might be confused with pulmonary hypertension because they have a flow or increased pulmonary blood flow causing pulmonary hypertension, where there is a hyperdynamic circulation resulting in pulmonary hypertension also. And in these conditions, the pulmonary blood flow is high compared to the previous condition where the pulmonary blood flow is going to be low. The third condition, where the pulmonary capillary wedge pressure is increased, can result from either left ventricular dysfunction or pulmonic vein stenosis or mitral stenosis or any other thing that's blocking the left side of the heart or pulmonary veins. And in these cases, the pulmonary capillary wedge pressure is increased, and this is a condition where you have post-capillary pulmonary hypertension. It's important to classify the patient that you have with PPHN into one of these three categories because the treatment of each of these three is very different. For example, nitric oxide can be very effective when the primary driver of pulmonary hypertension is increased PVR. On the other hand, nitric oxide is ineffective or even may be contraindicated when the primary etiology for increased pulmonary hypertension is increased pulmonary capillary wedge pressure. So it's important to figure out which of these phenotypes is causing pulmonary hypertension in your specific baby. The second way of considering this is think of a fetus. If you assume this to be a fetus in utero, and the vertical axis here is vascular resistance, here the lungs, there are two types of PVR during fetal life. The first PVR is pulmonary vascular resistance, and the second PVR is placental vascular resistance. During fetal life, the pulmonary vascular resistance is high, the placental vascular resistance is low, and for this reason, blood flows away from the lungs towards the placenta, which is the site of gas exchange. Despite having such rip-roaring high PVR, these babies tend to do perfectly fine without any issues. And the big question is, how does a fetus survive pulmonary hypertension? It survives pulmonary hypertension because of a couple of reasons. One, the right ventricular afterload, which is over here, is supposed to be really high because the PVR is high, but the blood bypasses the pulmonary circulation, goes through the wide open ductus arteriosus, and actually enters the placenta. So for this reason, the RV afterload is not increased in a fetus. In addition, the high fetal hemoglobin and cardiac output can maintain oxygen delivery despite low PaO2. The best PaO2 in a fetus is in the umbilical vein, which is approximately 35 millimeters of mercury. And in the umbilical artery, it's only around 20 to 25 millimeters of mercury. And despite this, a baby does quite well, despite this hypoxemia, and the baby does not suffer from hypoxia because it's able to deliver enough oxygen to the tissues. And because both the LV afterload and the RV afterload are both low, the baby or a fetus does not worry about low PaO2 and is happy with less cardiac stress. And this is the basic mechanism of how to manage babies with PPHN. So once the baby is born, if everything goes well, then the lungs start aerating and the pulmonary vascular resistance drops. We clamp the umbilical cord, and that results in increased systemic vascular resistance, and that leads to reversal of this pattern where more and more blood starts flowing into the lung, and the lungs become the site of gas exchange. But if this transition does not occur well, you'll end up with babies with PPHN. So let's think of reasons, the fetal secrets as to how a fetus manages to survive with severe pulmonary hypertension. Number one, the lungs are maintained at functional residual capacity with lung liquid. And as many of you know, keeping the lungs inflated at FRC results in the lowest pulmonary vascular resistance. Number two, the systemic blood pressure is normal, and this results in low LV afterload. keeping the ventricles happy is a really key thing to do while managing babies with PPHN. Ductal patency maintains low RV afterload, and this might be really critical in some babies, especially babies with diaphragmatic hernia, where ductal narrowing can result in increased afterload to the RV. And finally, having a high hemoglobin, especially fetal hemoglobin, is really, really important to survive fetal pulmonary hypertension. And the reason why fetal hemoglobin is really critical is because of its affinity to oxygen. So a fetus is a perfect parasite, and it has several secrets, one of which is to survive with relative hypoxemia without having hypoxia. And that's a unique feature of the fetus. And it's a perfect parasite because it tends to get whatever he or she wants from the mother, and the mother willfully gives every bit of nutrition that she has to her fetus. So I told you about the unique features of fetal hemoglobin, and this is a curve that you're all familiar with. The red line over here is adult hemoglobin or hemoglobin A that you and I have. And here is the purple line, which is fetal hemoglobin, which is shifted to the left in the oxygen hemoglobin dissociation curve. And then here is this dotted T line, which is fetal hemoglobin during therapeutic hypothermia. You need to realize the fact that when you put a baby on a cooling blanket for hypoxic ischemic encephalopathy, you're shifting the hemoglobin oxygen dissociation curve further to the left, causing more changes in hemodynamics. The second concept to understand here is that if you think of this pink zone with a PaO2 between 40 and 80 to represent normoxemia, if you have fetal adult hemoglobin, this range within this pink horizontal bar tends to depict the difference between the arterial PaO2 and venous PaO2, because the arterial PaO2 in normoxemia tends to be around 70 to 80 in babies, and the venous PaO2 is around 40. And this variation tends to result in adequate amount of oxygen being delivered to the tissues with hemoglobin A. With hemoglobin F, on the other hand, hemoglobin F functions much more effectively when there is hypoxemia, like what you would see during fetal life. Here is the blue bar, which represents an umbilical venous PaO2 of 35, and an umbilical arterial PaO2 of around 19. And when you have fetal hemoglobin, this range results in much more effective oxygen delivery to the tissues. The umbilical venous oxygen is up here. The umbilical arterial oxygen is down here. So there's a lot of oxygen that the baby can pick up during fetal life with fetal hemoglobin. A similar principle occurs during hypoxemia postnatally as well. So if you have a baby with pulmonary hypertension or hypoxemic respiratory failure who is hypoxic or hypoxemic, in that particular instance, hemoglobin F is a much more effective agent to deliver oxygen to the tissues than hemoglobin A. So for this reason, preserving hemoglobin F by minimizing blood loss is really critical while managing babies with PPHN. Okay, let's move on to one case. This is a case of meconium aspiration syndrome, and it's a 41-week, 4-day infant born to a primigravida by cesarean section for non-reassuring fetal heart rate. Mom is a smoker. She smokes around half pack of cigarettes per day, and she had thick meconium stained amniotic fluid at delivery, and the infant is floppy and apneic and has come out and is not vigorous. And because the NRP currently tells you not to do any tracheal suctioning, you don't plan on any of that. And the question to you is, when this baby is being born, what would your recommendation be for cord management to the obstetrician? Would you like the baby to receive immediate cord clamping? Would you like the baby to undergo deferred cord clamping for at least 60 seconds? Or do you want the baby to receive umbilical cord milking? I would urge you to put your choices in the chat so that we can have some ongoing discussion, so that I can see what you guys are planning or thinking. Okay, would you do immediate cord clamping, deferred cord clamping, or cord milking in this baby?
I think the chat is all directed to me, but we're getting answers of A. I have 1B, mostly A. Okay.
So that's the right approach. The NRP recommends that any baby who is not vigorous should undergo immediate cord clamping. But I want to point out to a new study that does suggest that there might be benefit with cord milking in some of these cases. Remember, this is not yet a NRP recommendation, but it's a fairly important study done by Anup Khateria and his colleagues, where they took a fairly large number of non-vigorous term infants. The N was 1,730 infants, where these non-vigorous infants were randomized to either umbilical cord milking ×4 or early cord clamping. Again, these were non-vigorous infants who were randomized to either umbilical cord milking or early cord clamping using a cluster randomization technique with crossover. And there are various results shown here. The first number that you see here is the results of the umbilical cord milking group. The second number shown here are the results of the early cord clamping group. And as you can see here, the primary outcome was reduced NICU admission, and there was no significant difference between the two. If you don't have an asterisk, it's not significant. But what was interesting was in this trial was that the babies who underwent umbilical cord milking had higher hemoglobin as expected, but had a lower incidence of moderate to severe hypoxic ischemic encephalopathy and also reduced need for therapeutic hypothermia, which was quite interesting. And also the incidence of Apgar score of 0 to 3 at 1 minute was lower with cord milking compared to no cord milking. So this same group went on to study the same issues further and followed some of these babies with oxygenation studies and echocardiogram studies. And this particular sub-cohort of the original study had only a smaller number of babies, only 227 babies. But what they found in this sub-cohort was that umbilical cord milking resulted in higher right ventricular output, higher left ventricular output, and reduced need for oxygen at 5 minutes. For example, the babies that underwent cord milking had only an FiO2 of 0.26 or 26% oxygen, whereas babies that were immediately cord clamped had a 86% oxygen need. So this is fairly interesting as to what this milking does, or added fetal hemoglobin does to the pulmonary circulation. So we really need more studies in this area before we can move forward. But for right now, as many of you pointed out, if you have a baby who is non-vigorous, the right approach is to provide positive pressure ventilation after immediate cord clamping. So moving on with the same baby, this baby had received immediate cord clamping, required positive pressure ventilation, was intubated, had pretty low Apgars, a very acidotic cord gas, was brought over to the NICU on conventional ventilation, 30/6 pressure, 60% O2. And then here are the settings: 40 per minute, tidal volume of 5 ml per kg. The baby is now on 90% oxygen with a mean airway pressure of 12. And here is the baby's X-ray, not looking so good. And an umbilical arterial line is placed, and the initial gas is still very acidotic. CO2 is 63, PO2 is 35. And the preductal saturations are 93%, and the postductal saturations are 75%. So now that you have this baby on a conventional ventilator, you take the umbilical arterial gas that you saw over here, and then you calculate oxygenation index. Remember, oxygenation index is mean airway pressure, which is 12, times oxygen, 90, divided by PaO2. Here is the PaO2 from the umbilical arterial line, and that's 35. That results in a pretty high oxygen index of 31. So your preductal sat is 93%, postductal sat is 75%. What do you want to do next? You already saw the X-ray. Increase PEEP, start inhaled nitric oxide, increase FiO2 to get a UAPaO2 of more than 100 millimeters of mercury, switch to an oscillator or a jet ventilator, check lactate and urine output. What would you do? I will let you answer the question since I can't see the answers. There is no easy right answer here. You may have to do many of these things for you to be successful in managing this infant. One thing I would definitely not do is increasing FiO2 further to get an umbilical arterial PaO2 of more than 100. This is definitely not the right answer. Thus, one thing for you to remember is in these cases where there is a discrepancy between preductal oxygenation and postductal oxygenation, the umbilical arterial gas might reveal a very high oxygenation index, but it's important for you to look at the preductal SAT and calculate a preductal oxygen saturation index using a simple formula where you basically multiply the OSI, or oxygen saturation index, which is mean airway pressure times FiO2 times 100 divided by preductal SpO2. And this gives rise to a number of 11.6 here. And if you multiply that by 2, roughly it's around 23. So this baby's preductal estimated oxygen index is around 23, which is way lower than the 31 that you had calculated using postductal gas. And so, in my opinion, you should use this number for therapeutic purposes to make decisions on this baby. The note based on two studies, one by Muniraman and colleagues and second by Dr. Munmun Rawat and colleagues, they have both shown that this particular formula of oxygen saturation index is only effective if the SpO2 is in a mid-range. If the SpO2 is extremely low or if it's extremely high, because of the flat portion in the terminal section of the oxygen dissociation curve, this formula does not really work. In fact, Muniraman and colleagues have come up with a much better formula, which is much more complicated, that you can find in their paper and use that for conversion as well. So the thing to remember with oxygenation is that the preductal oxygen is really what that matters. And during fetal life, the fetus mainly targets preductal oxygenation because that's what supplies the coronary circulation and that's what supplies the cerebral circulation. For this reason, preductal SpO2 is really the key value that you need to target while managing these babies. And using the same principle postnatally, many centers target preductal SATs of 85 to 95 and postductal SATs of more than 70, especially in babies with diaphragmatic hernia. But I would rather prefer to have a slightly higher range of around 90 to 97 for preductal saturations and more than 80 to 85 for postductal saturations. All of these measurements are based on the assumption that the baby's lactate is normal and the baby's urine output is adequate. If both of these are not true, if the baby has lactic acidosis and oliguria, that clearly indicates that there is postductal hypoxemia and postductal ischemia, and you should really target at improving your hemodynamics in those patients. So also consider having, in addition to preductal and postductal SAT monitoring, consider having NIRS monitoring as well, because changing NIRS values, especially cerebral values, can indicate inadequate oxygen delivery to the brain, and that's something that you should be able to avoid. So use all these parameters to figure out what the optimal oxygenation should be for your baby. So the second answer as to how much oxygen we should give to prevent PPHN or reduce the effect of PPHN is based on trials that came out from Dr. Abe Rudolph. He was a pioneering cardiologist at UCSF who did some seminal studies, and way back in 1966, probably before your parents were born, he came up with this beautiful paper where he showed that when the PaO2 falls below 45 millimeters of mercury, there's a huge increase in pulmonary vascular resistance, and this is what is called as hypoxic pulmonary vasoconstriction, and this is something you should avoid when you're having babies with PPHN. On the other hand, if you increase the PaO2 further, especially above 100 millimeters of mercury, you don't get any further reduction in pulmonary vascular resistance. So the conclusion from this graph is that hypoxia causes pulmonary vasoconstriction, that you can see over here. Normoxia causes pulmonary vasodilation. You see that between 50 and 80 millimeters of mercury in this region. But hyperoxia, when the PaO2 exceeds 100 millimeters of mercury, does not cause any additional pulmonary vasodilation, and in fact can cause oxygen toxicity. Here are two pulmonary arterial samples from lambs from buffalo that were ventilated with either 21% O2 or 100% O2. And the red stain here is superoxide anions or oxidative stress markers. As you can see here, both the airway and the pulmonary artery light up with superoxide anions when you use 100% O2. So giving too much oxygen can be harmful to these babies' lungs. The second thing to remember is that although it's easy to say that there is one nice little change point of around 45 to 50 millimeters of mercury, that's not really true across all the variations in pH. For example, if you have a baby who is really acidotic with a pH of 7.1, this change point is around 55. It's much higher. On the other hand, as the pH gets normalized, the change point also decreases. So having acidosis, this will exacerbate hypoxic pulmonary vasoconstriction. So you can't really equate a pH. You should know exactly what the baby's pH is for you to determine optimal oxygen saturations. A baby who is acidotic requires more oxygen than a baby who is not acidotic and is having normal pH. And this is something for you to remember, because if you have significant acidosis, it might be important to target SpO2 preductal between mid to high 90s, somewhere between 92 to 98% in 3 conditions. One, when you have acidosis, when you're using hypothermia because of the leftward shift in the oxygen dissociation curve, and also based on how much FiO2 this baby is needing. The fourth factor to consider is baby's race. And during the peak of COVID, several studies came through which suggested that African Americans or people with dark skin might be suffering from what is called as occult hypoxemia, where their pulse oximeter would not target or would not pick up adequate the SpO2 appropriately. In other words, there might be some individuals where, although the pulse oximetry values are normal, showing above 90%, if you do an arterial blood gas in these patients, their oxygen saturation by co-oximetry is less than 88%. So this entity, where pulse ox is normal, but the arterial blood gas shows hypoxia, is called occult hypoxemia. And the incidence of occult hypoxemia is much higher in Black children compared to white children. So there are some studies going on in this country right now, including one here at UC Davis, where we are trying to understand what is happening in these babies and how the skin pigmentation can influence pulse oximetry. So in the meantime, you should be cognizant of the fact that periodic blood gas checking is probably important while managing PPHN, and over-reliance on SATs might not be helpful, especially if the baby has dark skin. So to conclude this particular section, we really need a precision medicine approach to oxygen in PPHN. You can't have one fixed guideline for a baby because physiology keeps on changing and you need to change with changing physiology. For example, I mentioned to you that if you have a late preterm or a term baby with PPHN, a SAT range between 90 and 97 is probably adequate. All of these are preductal saturation ranges. On the other hand, if you have a preterm baby without PPHN, based on the NeoProm trials, many of us use saturations between 90 and 94%. If you have a baby with preterm with pulmonary hypertension with BPD, these babies, it's recommended to have SATs between 92 and 95%. On the other hand, if you have a term baby with PPHN with hypothermia, acidosis with pH less than 725, or we really don't know this yet, but if they have dark skin pigmentation or if the baby is not on very high O2, it might be okay to target slightly higher numbers between 92 and 98 in these babies. Anyhow, SATs of 99 and 100 should be avoided because if a baby is on supplemental oxygen and is saturating between 99 and 100, there is a very significant risk of oxidative stress in these babies. So these two SAT numbers should be avoided. But individually, you have to assess every single baby, assess the pH, assess the situation the baby is in, hemodynamics, etc., and then determine optimal oxygen saturation for these infants. Moving on, the same baby now has signs of HIE and baby's on whole body hypothermia. Baby was having seizures, got some phenobarb, the blood pressure dropped. The mean is now 35 millimeters of mercury, 55 by 25 are the pressures. And the infant continues to require 80% O2. We repeat a blood gas on an oscillator. Venous pressure now is 17, 715, 45, 40, 15, minus 12. And you get an echo done on this baby. The echo shows significant LV dysfunction. And the tricuspid regurgitation jet is around 4 meters per second. And if you calculate using the modified Bernoulli principle, the right ventricular systolic pressure is around 65 millimeters of mercury. So now what do you want to do? Increase the inspired oxygen to 100%, start sildenafil, start dopamine and increase systolic blood pressure, start milrinone. Which of these would you do? Assuming the baby is already on inhaled nitric oxide. So put your choice in the chat and we'll follow this up later. And again, there is no easy right answer or wrong answer here with these patients. The key thing to remember here is that this baby has left ventricular dysfunction. And in the presence of left ventricular dysfunction, you should be very cautious about using pulmonary vasodilators. So the only vasodilator that's approved in newborn babies, especially for PPHN, is inhaled nitric oxide. And inhaled nitric oxide is typically started with a dose of around 20 parts per million. And the beauty of inhaled nitric oxide is that it's an inhaled agent. And so it enters only alveoli that are ventilated and does not enter alveoli that are not ventilated. And for this reason, it selectively opens up pulmonary blood vessels adjacent to a ventilated alveolus, causing ventilation perfusion matching, resulting in improved oxygenation. The second advantage with NO is that once it's absorbed into the systemic circulation, it gets inactivated by hemoglobin to form methemoglobin. And for that reason, there is typically no reduction in systemic blood pressure with the use of inhaled nitric oxide. And so it is a selective agent. It selectively acts on the pulmonary circulation. It's a microselective agent. It only acts on ventilated alveoli and not on non-ventilated alveoli. So even babies who don't have PPHN might show some increase in oxygenation following the use of inhaled nitric oxide. So there are a few conditions where inhaled nitric oxide is contraindicated. One is if you have congenital methemoglobinemia. For this reason, it's better to check a blood gas and methemoglobin level before starting nitric oxide. Two, if you have LV dysfunction, either due to congenital diaphragmatic hernia, asphyxia, sepsis, or post-cardiac arrest, these babies tend not to behave well because they have high pulmonary capillary wedge pressure. And then if a baby has a ductal dependent systemic circulation and a congenital heart disease, for example, hypoplastic left heart syndrome or critical aortic stenosis, in these conditions, systemic circulation is dependent on the right to left shunt across the PDA. And if you drop the PVR in these conditions by giving nitric oxide, these babies will develop severe lactic acidosis. So for this reason, these conditions are also contraindications for inhaled nitric oxide. Knowingly, nobody would use them, but when you are out on transport and you pick up a baby and you don't know the diagnosis, sometimes erroneously nitric oxide can be used in congenital heart disease, and especially if you have heart disease that causes ductal dependent systemic circulation, or if you have an obstructed TAPVR, both of these can get significantly worse with the use of inhaled nitric oxide. So here is one case where you see a significant evidence of LV dysfunction. Here is the RV contracting reasonably okay, and here is the LV poorly contracting with a ejection fraction of around 38%, which is pretty low. And here also you can see the LV not contracting well at all. And the baby has a bidirectional PDA shunt. If you have these signs suggest that the baby has significant LV dysfunction, and it's probably better to avoid inhaled nitric oxide in this particular situation. So what happens when you use inhaled nitric oxide? If you have significant LV dysfunction, as you can see in asphyxia, congenital diaphragmatic hernia, or sepsis, this LV dysfunction in turn results in increased left atrial pressure. This left atrial pressure results in a left to right shunt across the PFO, although the baby has pulmonary hypertension and has a right to left shunt across the PDA. This in turn results in pulmonary venous hypertension because of increased back pressure here, resulting in pulmonary edema. Now, if you give this baby inhaled nitric oxide, that's almost like having a party with a blocked toilet, and the block here represents LV dysfunction, and giving inhaled nitric oxide is the same as flushing this toilet. If you keep on flushing this toilet, it causes overflow and damage, and this is what happens with pulmonary edema. On the other hand, the right treatment for this condition is to use an agent such as milrinone, which improves LV function. That's almost like using a plunger to clear the obstruction, and after which, once the LV function improves, you can go ahead and use inhaled nitric oxide. And that's the reason why, in the presence of LV dysfunction, when that's the primary etiology of the problem, use milrinone first and then use inhaled nitric oxide after LV function improves. However, there is increased caution nowadays with the use of milrinone because milrinone can cause significant systemic hypotension. And if you have renal compromise, this renal compromise can lead to worsening of systemic hypotension. And this was shown elegantly by the group from Iowa, where they looked at babies undergoing hypothermia. And what they showed was that in babies with PPHN without HIE or therapeutic hypothermia, milrinone did not cause a huge change in systolic arterial pressure. On the other hand, when babies with therapeutic hypothermia were subjected to use milrinone, they saw a huge drop in both systolic pressure and also diastolic pressure, mainly because these babies had higher creatinine and lower renal function. And as many of you know, milrinone is excreted by the kidneys, and renal dysfunction tends to prolong the half-life of milrinone, causing more systemic hypotension. So if a baby is not responding to inhaled nitric oxide, what should you do? You have various choices. You can use drugs such as sildenafil. There's a new drug for adults called riociguat, which is a soluble guanylyl cyclase activator. You also can improve hemodynamics by using milrinone. But the key reason why most babies don't respond to inhaled nitric oxide is because the lung is not recruited. If the lung is not recruited and the nitric oxide cannot get to its target organ, which is the pulmonary arteriole, it will not act. So recruiting the lung is probably the key thing you need to do before initiating inhaled nitric oxide. And that's one of the main reasons. Not getting access to the target organ because of poor lung recruitment is one of the commonest reasons as to why inhaled nitric oxide does not work. And one way to recruit the lung is to use surfactant. Here is a very nice randomized trial from Chile where they showed that when you use surfactant with inhaled nitric oxide, you get a better drop in oxygenation index compared to using inhaled nitric oxide alone. And I believe the reason for this is that if you give inhaled nitric oxide to an asymmetrically distended lung, it's only distributed to selective areas and does not go to the collapsed alveoli. On the other hand, if you give surfactant and open up the lung uniformly, then nitric oxide is much more effective in acting because it reaches the target pulmonary arterioles. So if you have parenchymal lung disease, please use inhaled nitric oxide. Please use surfactant first and then recruit the lung and followed by inhaled nitric oxide. Here is an X-ray from one of my colleagues, Dr. Vikram Dumpa, which shows that the lungs, when they're underinflated, the nitric oxide was not acting in this baby. And then he switched this baby over to an oscillator and then gave a dose of increased mean airway pressure, gave a dose of surfactant, and that resulted in much better opening of the lungs and increased effectiveness of inhaled nitric oxide. So recruit the lungs, open up the lung to FRC, and then use inhaled nitric oxide. So 2 quick points before I end this section of the talk. In some patients with pulmonary hypertension, increased afterload results in a positive effect on the heart. Here, the right ventricle hypertrophies, the right ventricle contracts much more vigorously, the heart rate goes up, and there is mild RV dilation. And this is what is called as RV coupling. In other words, as the PA pressure keeps going up, the RV functions harder and harder to keep up with this. And this is called coupling or homeometric adaptation. On the other hand, once things get really bad, for example, the RV dilates so much that it's compromising the LV, and that results in coronary ischemia, leading to right ventricular hypoxemia, ischemia, and myocardial stretching. In these cases, and also if the ductus starts constricting, it starts causing such high afterload that the RV can no longer keep up. And in these cases, RV starts failing, and this is called uncoupling or heterotopic maladaptation. When you see something like this needs to be addressed by a few things. For example, here is a echo with severe RV dysfunction. And as you can see, the TAPC is pretty low. Usually it should be 9, it's down to 3. And then you also have significant RV dysfunction with a closing ductus. In such situations, it's better to use a combo of 3 medications. Inhale nitric oxide to open up the lungs, open up the pulmonary vessels to reduce pulmonary vascular resistance and reduce RV afterload. Milrinone to improve function of the right ventricle, and IV PGE1 to open up the ductus so that the afterload is reduced because the blood can pop off into the systemic circulation. So this combination of INO, PGE1, and milrinone is quite effective in these particular instances. And if you have any evidence of severe RV dysfunction with the closing ductus, consider using IV PGE1. The last section here is blood pressure. Many patients with PPHN have systemic hypotension, and dopamine is a commonly used drug in these instances. And when you use dopamine, you not only increase systemic blood pressure, but you also increase pulmonary blood pressure. So dopamine is not selective to systemic circulation. For this reason, I'm not in favor of using dopamine for PPHN in the NICUs, especially in PPHN. So if you want to use dopamine in other patients, that's probably okay. But especially in babies with PPHN, dopamine being not selective is not the ideal agent. Instead, I really like using norepinephrine because norepinephrine acts on alpha-1 receptors in the peripheral vasculature and increases systemic vascular resistance. But there are some alpha-2 receptors in the lung that are supposed to cause some nitric oxide release. And for this reason, norepinephrine is a much more selective systemic vasoconstrictor. So norepinephrine is my first choice of vasopressor in babies with PPHN. And there is one study from France which has shown that the use of norepinephrine at a fairly high dose that's shown up here results in reduction in FiO2, improvement in the postductal SATs, and a selective increase in systemic arterial pressure with only a small increase in pulmonary arterial pressure. So the PAP to SAP ratio, the pulmonary to systemic pressure ratio, actually goes down with the use of norepinephrine. So use of norepinephrine should be considered, and in my opinion, this should be the first line agent for blood pressure management in babies with PPHN. But be aware that it can cause significant cardiac dysfunction because it selectively increases afterload without inotropy. And in case you have cardiac dysfunction, you may need an inotropic agent as well. The second drug that's equally selective and probably can be used is vasopressin, and we use quite a bit of this as well. But the main adverse effect here is hyponatremia. Many of these patients develop significantly low sodium, so you should carefully monitor sodium and also urine output in babies when you use vasopressin. The third drug that you should consider is hydrocortisone. We usually use a slightly higher load of around 4 milligrams per kg initially, followed by 1 mg per kg every 8 hours, and then switch over to maintenance hydrocortisone. And this has been shown in a small study from Buffalo to improve systolic blood pressure, decrease inotropic score, improve oxygenation, and finally improve PaO2. But be careful about occult infection, fungal sepsis, viral sepsis, etc., because all of those can be exacerbated by the use of steroids. So to conclude, this patient had required milrinone, PGE1, hydrocortisone, and inhaled nitric oxide. O2 gradually came down to around 30%, completed 72 hours of cooling, and was eventually weaned off all the medications and did quite well. Remember that having very good communication between nursing, respiratory therapy, your cardiologist is really, really important while managing babies with PPHN. And this is a dynamic disease where management changes with baby's physiology and time. And I thank you for your attention. Just to highlight that Dr. Steve Abman and I will be editing an issue of clinics on PPHN. And many of the figures that you saw in this presentation will be in this book, and it should be out hopefully in February or March next year. That concludes my first talk. I can either take questions or jump into the second talk.
Yeah, why don't we field there were a couple of questions chatted in. One of them was about if you're intubating and you see meconium coming out of the larynx during intubation, do you suction that first, aspiration first, followed by intubation in terms of managing meconium aspiration syndrome?
Okay. As you know, that's an area of high controversy, but based on current guidelines from ILCOR and the NRP, unless there is respiratory obstruction and you're not able to ventilate the lung, that's the indication for suctioning. Many senior neonatologists prefer suctioning, and the younger people don't. So there's a big age divide. If you did your fellowship before 2010, many people would like to suction a bit. And if you did it after 2010, you prefer not to do it. But the current recommendation is to initiate PPV first. And if you can't ventilate the lung, and if you can't open up the lung, then you go ahead and suction and remove any obstruction that's present.
Thank you. Then the other two questions that were chatted in are somewhat related and are about optimal saturations. So in some babies, when you have labile saturations, what is your preferred management about that? And then also, what would you say the optimal saturation is for a baby with persistent pulmonary hypertension? Greater than 92% versus what we sort of classically have approached, which is greater than 95%. So your comments on that?
Yeah, so if the fluctuating SpO2 is post-ductal, I usually don't worry about it because that's what you expect. I mean, the hallmark of PPHN is labile hypoxemia, and especially the post-ductal sats are going up, that just means that there is more shunt. So I really don't worry about that much. I prefer to have sats between 90 and 97. The recommendation from the European Pulmonary Vascular Disease Guidelines is 91 to 95 preductal. But I believe that having a narrow target makes nurses' life miserable by trying to maintain FiO2. So for that reason, I tend to go a bit wider between 90 and 97. And there is absolutely no reason to maintain preductal sats of 98, 99, and 100. So that should be absolutely avoided. And in the three conditions I mentioned, if you're severely acidotic, if you are undergoing therapeutic hypothermia and have significant PPHN, and possibly if your skin pigmentation is dark, if the patient's skin pigmentation is dark, it might be better to target somewhere between 92 and 98, slightly higher numbers. But under any condition, I'm not in favor of using 99 and 100%. So that's too much. We have a small trial going on here at UC Davis where we are comparing 90 to 94 versus 95 to 98. And it's been hard to recruit. So hopefully we will launch a bigger trial and then we will take it from there.
Thank you.
Okay. I just have 14 minutes. So let me launch my talk number 2. Which is on leadership. So this is probably a slightly longer talk than I had thought, but I'll get through it reasonably fast and I can take questions later for people who want to stay back. So this is about the role of women in leadership in neonatology. And what I want to do in the next 10, 15 minutes is to review types of leadership opportunities, benefits of taking up a leadership track for women, and outline the negative aspects of taking leadership positions. It does come with stress, and talk briefly about the triple threat or the quadruple threat and its challenges for female faculty. Okay, this is my outline, but I will go through this as we go along. Just to give you a brief, my background as a leader, as many of you know, and as Dr. O'Reilly mentioned, I was a lab rat between 2004 and 2010. And that was probably the happiest time in my life where I did not know anything about finances and I was doing really well in Buffalo. As many of you, I see many colleagues, my former colleagues here on the call. Then, unfortunately, I became a division chief of neonatology in 2011 and survived that for over a period of 7 years and became a vice chair towards the end for a year. Then I moved here to become a chair at UC and I've been a chair here for almost 6 years now. This is a very interesting transition because when you are a neo chief, you're the darling of the hospital CEO because you're the money-making unit. And then you become a pediatric chair. And then you are in a very bad situation because the Department of Pediatrics in general doesn't make much money. So you move from being a revenue-generating neo chief to a revenue-neutral or a negative pediatric chair. And that transition was very difficult for me. I had a hard time trying to understand ambulatory pediatrics, etc. Subsequently, I became a co-chair of the UC Davis Health Funds Flow, which basically regulates and looks into salaries of all 1,400 faculty here at UC Davis. And that was a very interesting transition, trying to understand how surgery works, how internal medicine works, etc. And more recently, become the chair of the Clinical Care Committee for AMSTAC, which is the Association of Pediatric Chairs. And that has given me a much broader outlook on what's happening across the country with academic pediatrics. So a neonatologist, every one of you is like an octopus. You're multitasking all the time. You're dealing with issues with quality improvement, being a physician, being an administrator, coding and billing, being a finance manager, also being a teacher to medical students, respiratory therapists, whoever comes across your way. Plus you have to manage night calls, you have to coordinate care. This is like a never-ending thing. And adding leadership on the top of this seems like a really big burden sometimes. The second thing to remember is that when you look at the number of physicians who are satisfied that work leaves enough time for personal or family life, this number keeps changing. General surgeons are way down here at the bottom. General internal medicine, family medicine, emergency medicine, psychiatry, and general pediatrics. In this particular entity, general pediatricians do really, really well across the spectrum of all providers. On the other hand, pediatric subspecialists are way down here. So what's going on that results in such a drop in work-life balance and family and work satisfaction from general pediatrics to pediatric subspecialists? And that's a really intriguing thing. And that is something that we need to investigate further. The second change that has happened more recently is the change in demographics or the gender distribution of neonatology fellows. I did my fellowship in 1996, probably the oldest person in this current group here. And during that time, the gender distribution was almost equal with some male dominance among neonatal fellows. But just within a span of the last 14, 15 years, between 2008 and 2022, from the ABP website, you can clearly see that the percentage of female fellows, this is all the trainee count, all 3 years, has gone up from 60.9% to 72.4%. In other words, 3 out of 4 graduating fellows currently are female. Showing this in a much more dramatic fashion is the same graph. Here is the percentage number of male trainees in neonatology, and here is the number of female trainees in neonatology. So this number is going up year by year, and it only makes sense that the leadership of this group should gradually shift and become increasingly female, because right now there are more male chiefs in this country in neonatology than female chiefs, although the whole demographic of the neonatology pool is changing. So it's always good to have a leader who represents the community better. And so for that reason, we really need more female chiefs. And that's the reason why I urge every one of you to consider taking on an administrative position as you advance in your career. The second thing, or second piece of advice, as somebody who is older than you, I want to deliver is, if an opportunity knocks on your door, please consider it. And it's not uncommon when I ask one of my colleagues in the department to take on some role and they hesitate to do it because everybody views administration as something evil. And what I recommend you do is think about the title and the responsibility, because they are important for the advancement of your career. And try to negotiate a stipend or time, protected time for doing this effort. If you're successful, that's awesome. Even if this negotiation fails, with your chair, chief, or CEO, talk to your mentor. Every one of you who is an academic pediatric should have a mentor, and this mentor should be outside your division. Have somebody outside neonatology be your mentor, because then that person will be very neutral to your division and will give you the best advice. My mentor for these purposes during my junior faculty term was a vice chair of physiology who would give me very solid advice that really helped me in my career. So if you do not take this opportunity, someone less qualified than you might take that position. And that's something also to remember as to why you should choose it. And try to get a small title and have some responsibility assigned to you relatively early in your career, because that will show that you're capable of doing administrative tasks, and that will really help you in your career. How do you start getting a leadership job? It's similar to what happens with presidency. I know we are going through a set of primaries again this year for elections next year. So you can have many people either become a senator and then advance on to become a president, or you become a governor and then advance on to become a president. And rarely you don't do either one of these, like our previous president, and then you can become a president too. So there are different pathways. And the equivalent of a senator in our situation is being an associate fellowship director or a fellowship director. And being a governor is somebody who is being a medical director or assistant medical director, and then you advance on to become a chief. So think of these positions when you consider leadership positions. It could be something small like being a director of outreach or respiratory therapy or newborn screening or something like that. It's important to have a title associated with your job. Whether you get time or money for that effort is less material, in my opinion, than having that particular title. So choose to go down the assistant medical director path. If you have an inclination towards policies and procedures, you're really a big people's person and you can work with nurses, nurse practitioners, respiratory therapists, etc. And if you're good at quality and safety, transport, respiratory care, and those things. On the other hand, if your education is your main goal, and if you don't mind dealing with paperwork, and if you're really good at mentoring, then choose to go down the associate fellowship director path or a fellowship director path, because that's more into education. And both of these are very effective ways to become a future chief. There are other jobs such as director of outreach, respiratory therapy, etc., that you can also choose from. So the second principle I want to recommend to you is based on an ad I saw for eyeglasses. Most of us wear eyeglasses. I wear my eyeglasses because I need them to see good. But it's also important to look good when you wear your eyeglasses, right? Seeing good versus looking good. You need both of those when you buy a frame or buy eyeglasses. Similarly, it's not only important to do some work in the NICU, but also that work should appear to be done. In other words, the work you did should be seen, should be on the radar of your chief, your chair, maybe the dean, and more importantly, the nurse manager and the hospital administrator. Just doing, many of us are very humble, and this is much more common among women, that they do a lot of hard work, but that they don't really worry about visibility because they are used to doing hard work and not being visible. But in the hospital, it doesn't work out that way. If you do some job, make sure that people realize that you did that job, and that's really important. So work should be done, but it should also appear to be done. And getting the hospital CEO or the president to know that you're really critical, that what you do is really critical for your career advancement. So whoever is in your leadership position should know how hard you're working. Then the next thing is gender equity, especially during the first 5 to 6 years of being an assistant professor, is really hard. I mean, you're trying to do your research, do clinical work, administrative work, and many of times during this period, you need childbearing leave, you have young children at home, caring for them, unfortunately, even to this day, disproportionately falls more on mothers than fathers, and that is a big issue. And so these years are really, really important for you. And I can remember the days when I was a fellow, many of my colleagues were pregnant and they had to finish all their service, finish everything that they had to do for the year before they could go on maternity leave. And they used to do so many night calls when they were like 8 months, 9 months pregnant. And this was like, what is the purpose of neonatal fellowship? Is it meant to induce preterm labor? It was almost like that. So things have gotten a bit better now. And especially for junior faculty, you reduce the clinical load by 25%. In other words, they don't have to pay back for the time they take off for childbearing. And recently we are trying out in our unit what we call as lactation value units, where we provide some credit for breaks that a mother takes, a junior faculty member, mother takes while expressing breast milk and things like that. Reduce productivity expectations during this period, because we don't want a junior faculty member to feel that, oh my God, I had this child and so my work hour views are low, I've not been able to produce enough research. All these expectations should be proportionately reduced during this period. And it's also important to annually review compensation between genders. So I have a really nice statistics professor in my department who does these graphs for me. And the way this works out with these graphs is that you compare female and male salaries using a Z-score. You take the total salary, including bonus. And if you're at median, then you're hitting 0 here. And if you're at -1, you're 1 standard deviation below what is expected. So we use national benchmarks for these. And this was where we were in 2019 prior to instituting what is called as funds flow standardization. And this is the female group and the male group. And you can clearly see the difference. The male salaries were much higher than female. And thankfully, more recently, all the salaries have gone up with the institution of funds flow, and the difference is still there, but it's marginally low. So every year, it's important to analyze your own department or your own group to make sure that there is no gender discrimination in equity or salary. The second thing is understanding finances. To become a good leader, you have to understand finances. And just to give you a quick example, the thing that really bugs me as a neonatologist is the fact as to why physician compensation should be based on patient size. Here is the median salary plus bonuses, plus moonlighting, etc. for an adult pulmonary critical care medicine person. Here is the salary for a pediatric critical care person. Here is the salary for a neonatologist. There is no reason as to why the adult person should be paid more. It's not like a 500-gram baby is any less complex than a 200-kilogram patient. So we deal with equally complex patients, and our productivity is pretty high. This is the annual work RVUs that adult critical care produces, pediatric critical care produces, and neonatology produces. We produce almost twice as many work RVUs as they do. And when you actually divide the salary by work RVUs, it's very clear that patient size does matter, because the dollars per work RVU that we get is significantly lower in neonatology compared to pediatric critical care, and it's further lower than adult critical care. So although we all do similar amount of work, there is discrepancy in salaries, and understanding finances is really critical to fight against such discrepancies. A common question I get asked is, should everybody do an MBA? Getting some financial knowledge is really crucial. And if you have the time to do an MBA, it's probably not a bad idea if you have administrative aspirations. The question is, when do you do it? It's very difficult, in my opinion, to do it during fellowship. So junior faculty years is probably the best thing to do. And people like me who are too old to do any of these things, I have gone and taken some 2 to 3 week courses, a quick understanding of finances in healthcare that many universities run, and it's worthwhile attending one of those courses. So what are the benefits of administrative responsibilities? You have power. Power is important. And you have the ability to do greater good for more people. And as I said before, if you don't take this job, someone less qualified than you will take the job and will become your boss. Think of that before you say no. You never know. I mean, in my case, I was a lab rat, and I knew for sure that I would hate being an administrator, but I started enjoying it, and I really liked being a chief. And then now I'm a chair, and I deal 90% of the time I work on finances, administration, and things like that, and I enjoy it. You also can make a difference in someone's life because you have administrative power and financial power. You can really help people, especially mentoring young faculty and making sure that are successful in academics is probably the best part of my job right now. You can enhance diversity, and you can bring about salary equity for everyone. One other thing, obviously, is that your salary will go up when you become a chief or a chair, and there's only one way to reach high salaries in pediatrics is to take on administrative positions. And here is an X-ray that many of you can realize that there's something wrong with this X-ray. It doesn't have a heart, and it's generally commonly made fun that CEOs don't have a heart, but it's absolutely not true. CEOs are perfectly normal human beings. We just need to know how to appeal to them correctly. So when you go to ask your CEO for something for the NICU, think of the things that matter to him or her. For example, if the person is really keen on US World News rankings, tell him that, oh, if you get this particular thing to the NICU, you will have better rankings in US World News. Figure out what appeals to that person and use that particular thing to appeal. You need to have a lot of abilities and features to become a good chief. Traditionally, we used to think that being vigilant, being a visionary, being knowledgeable, tactical, and having financial understanding is what is required to become a physician leader. And that was when more and more men were becoming chiefs. But increasingly, it's being realized that many other qualities, which are inherently much better among women than men, are really, really important to become a good chief. Intellectual curiosity and focus, transparency, courage with humility, ability to include diversity, equity, and inclusion, compassion, especially important, being ethical, and being the ability to communicate with respect, and being adaptable. These are all qualities that are more common among female leaders than male leaders. And for this reason, we really need more female leaders in neonatology. I will briefly talk about the quadruple threat. It's not easy for people to be the best in teaching, clinical work, admin, research, and everything. And the classic triple threat is slowly fading away. We don't want to be superhumans. We want to be really good, compassionate humans. And developing expertise in one of these areas is probably more than adequate. There are several common leadership styles, but majority of women tend to choose what is called as a servant leadership style, where you are humble, protective, and you lead from behind. And that style does not work all the time. You have to be a situational leader. There might be instances where you need to be an autocrat. There is nothing wrong with that. There are some situations where you need to be a democratic person. There are some situations where you need to be a visionary. So based on the situation, you have to pick and choose what kind of leader you want to be. And it does come with administrative headaches. I won't say no. I get more than 200 emails a day. And by the time I clear my emails, I have no more energy left in me. And that's not fun. And I walk into the office in the morning thinking that I will write a grant or write a paper. And then some small quarrel starts between two people that you didn't even know. And you spend the whole day resolving that. And just to give you an example, this is how I was when I was a junior faculty member. This is how I look when I became a chief. And this is how I look when I became a chair. So it causes gradual deterioration on you. But if you like it, you will enjoy it. To conclude, it's important to enjoy your work. If this is what brings you happiness and satisfaction, please consider doing it. You should have the ability to balance the budget, and it's really important to delegate tasks to others. And when you go to your dean or CEO or your chair to ask something, don't go with more than 2 asks. People have very small attention span. So think of something small to ask. And being a leader is a pretty difficult task, whether it's a chief or a chair, because you have to appeal to people above you. You have to make sure you appeal to people who you're responsible for. And making everybody happy is really important, but you can never achieve that. You will never be able to make everyone happy. the key to success is to make the maximum number of people that you can happy, and you don't worry about a small proportion that you can never succeed in making happy. So to conclude, do not hesitate if a leadership opportunity comes knocking at your door. You can make a difference in careers and lives as a leader. Leadership can be fun and exciting. You can shape the future of academic neonatology and pediatrics, and women in neonatology are ideal candidates for leadership in neonatology and pediatrics. So you should become chiefs and chairs and deans and beyond. And I really strongly encourage all of you to consider a leadership position. Thank you so much, and sorry for exceeding my time. If anybody still is patient, I'm happy to answer questions.
No, that's fantastic. Thank you so much. This was wonderful. And I have a lot of requests for the slides. So if you would share those with me, I'm happy to distribute them to the people who asked for them. And really just overall appreciation for such an amazing talk, and for your work both with PPHN and leadership tips and things that we can really do to improve the field of neonatology.
Thank you, Deirdre,
so
for
much.
the opportunity. I'm happy to take any questions, or people feel free to email me as well, whatever works.
Wonderful. Thank you so much.
Thank you.